Hello, everyone. Welcome back to the YAB Teen Health. My name is Samantha, and today we'll be talking about how mental health starts early. Henning, thank you so much for being here. Would you like to give us a little introduction about yourself to start us off?
Well, first of all, thank you very much for inviting me and running this podcast. Yes, so my name is Henning Tiemeier, and I'm a professor at the Harvard School of Public Health here in Boston. And I'm in the Social and Behavioral Science department, so I'm a professor of social and behavioral sciences. And I'm the chair in maternal and child health. And within that broad area, my interest lies in child development and child and adolescent mental health. So that's where my research is. And it's often about how and why do mental health problems in adolescence occur and how the early life and family environments shape these problems.
Thank you. Very accomplished. Okay, so my first question for you is, what are some differences in how this younger generation views mental health compared to the older generation? I remember when we spoke, we talked about tolerance, and you said how the older generation is a lot less tolerant compared to the younger generation.
Yeah, so that's indeed what got us talking and is why we sort of sit here together now when we chatted when we met. If you talk about older and younger generation, there's two things I want to separate, although they go together. Are you talking or are we talking about age differences or differences in time, meaning the generation of adolescents now versus the generation of adolescents 30 years ago? Why is that a difference? Because even in older people, the views on mental health have changed in the last years. So there's two factors. One is it changed how you view mental health problems changes with age, but it also changed in the last 30, 40 years. So if we make this, we can try to, differentiate these problems. And to me, and what we started about is really there is I would say, generational change or a change in the last 30 years, how we talk about mental health problems, how we perceive them, and how we report them. And that's perhaps where we should focus on. So, having said that, if that's what we want to talk about, let's do it and say the first thing is that we noticed since the early 2000s an increase in mental health problems reported by most of the population, but in particular by the adolescents. So it is probably quite pervasive, but it is very strong in the youth, that they have more problems than the youth 30 years ago. And that's quite remarkable because people I know studied the change in mental health problems from the 70s to the 90s and found no change. They said, this is a boring topic. Mental health problems are reasonably constant, even across societies, more than other diseases. It is, if you do it the right way, you find certain prevalences. And all of a sudden, in the 2000s, it changed. And it became very apparent with COVID when it increased again, but the change had clearly, definitely set in before. What are we talking about is, in particular, a change in what we call internalizing problems. And then you must think of anxiety problems, depression problems, to some extent, sleep problems that have increased. And that has changed. And now we can ask why that is, but I don't know if that's the next question. We can continue.
Yes, you can. Please continue.
The question is, why on earth has this changed? But I don't think there's any doubt that it's changed. Even eating disorders has increased. And it has, the first thing we must also know, it's increased on all levels. So that means self-reported problems have increased, diagnosis has increased, and certainly treatment has increased. If it were only treatment, we could say, well, people are more aware or there's more access to treatment, but it's really also the self-reported problem. So we must have a situation where we must acknowledge that if you're 16, 18, something like that, you're more likely to report problems than you could say your parental generation 30 years ago. Why? Um, when we study this or teach this at Harvard, we have, I always say, everybody has his pet theory. So that means if I have 10 scientists, I get 8, or perhaps I get even 15 theories from 10 scientists. And so we can take them, a bit one by one. Um, there's many. There's some that you would not even think of first, like say, we see that the increase is in some ways very not yeah, dramatic, you could say, or very marked in girls. And we know for sure that girls become earlier in puberty than in the past. We see that pubertal development has advanced, so the onset of menarche and other indicators is much earlier, and we know that that is associated, certainly in girls, with more internalizing depression, anxiety problems. That's probably a smaller effect. It could be, it is explained in part by obesity, that we have more overweight, which is one of, contributes to this. That's one theory. Another theory is there is much we know that sleep duration in particular, has decreased in the last 20 years. So for several reasons, from school stress to social media use to lack of parenting strictness, we see that there is a reduction in sleep time. So with adolescents, you will find a biological drive to sleep less. That's very common. You like to go to bed earlier and get up later. That's inborn. We see that wears off later, but it's very common in adolescence. And if that's not carefully regulated, or if that coincides with sleep times, which in the US are very early, often 8 o'clock is a start date, 8:30 in high school is not uncommon, then that can lead to depression. We know that poor sleep lack is really related to depression. It's another theory. I'll do two or three more. One other theory is that we see a reduction of communal involvement, meaning that from Boy Scouts or Girl Scouts and religious groups or neighborhood groups have been less integrative of the youth and the activities. So it's much less, hanging out with your peers and perhaps adults in these groups and feeling a sense of community. We can see that religious attainment goes down, and these clubs sometimes go down, and it's a more fragmented, diversified society, and people have related that to the occurrence of depression. I don't know. There are people that think it's big, and I think there's less evidence for social pressure or as pressure at school, that the achievements has gone up, although there certainly is some groups of society. We see it very strong, for example, in cross-culturally in Korea and Singapore, where the school pressure has really related to internalizing depression, anxiety, suicidal problems in youth. There's not so much evidence that that went up in the US, for example, but it's clearly very high in some societies. Others have accounted for it with the use of cannabis, which has increased. Weed, again, I'm a bit doubtful. It's probably more common than we would like to think even 20 years ago. But it's quite clear that regular users, meaning, let's say, more than 2 or 3 times a week, suffer from mental health problems. And we think that has also increased. I don't think that's a big contributor, but I think it's something that in the current climate is, there's a big move to liberalizing cannabis, which there's positive things that you can gain from that, but there's also downsides that you find an addicted group, which is quite high in the adolescent group too, that use it, more than you would wish. So that's that. The other theory that's the elephant in the room is the social media, which I think we discussed. There's a big scientist, Haidt from New York University, that blames the whole adolescent mental health crisis on social media use. Now, the data is tricky to have because social media use changes every age year, but also in hindsight. TikTok wasn't available 15 years ago, Instagram wasn't available 20 years ago, or WhatsApp. So it's so quick changing that to show that over generations is very hard. But there is studies that show that there is an association. Others criticize that. I think the jury is out. I would say it's a very serious candidate. While I think there's even some positive aspects of using social media for messaging, there probably is quite a negative for just passively being and receiving film snippets, which is highly addictive. So there is probably that. And the last thing which we talked about, and it's a long answer, I know people will get bored by now, But go for your pet theory, is the over-awareness. So that is related to social media. It means, but it's not only that, it's a societal achievement, I would say. So what we discussed, what I want to point out, I have my own theory here that in the last 30 years, we have destigmatized some of the mental health problems to some degree. I'm saying that carefully because there's certain groups in society where it's not destigmatized, it's certain disorders where it's not stigmatized. It doesn't go in parallel. So you could say Asian Americans have more stigma still than other groups. You could say depression is much more destigmatized than schizophrenia. If you take pedophilia, it's certainly not destigmatized. If anything, it's absolutely not tolerated. So alcoholism, for example, is unclear whether that's really destigmatized. It's still quite stigmatized. But we know that the internalizing disorders have become much more. And there we see it also very strongly in boys, the destigmatization. Let me illustrate that. It is not uncommon anymore that a boy will say, I have anxiety problems, acknowledging that, talking to that about teacher or parents, which 30 years ago was unthinkable. And he would then be diagnosed and treated for. And there is a relationship between destigmatization, acknowledging it, talking it, and to some extent, probably being aware of it. That means it's positive that you're aware of it, you can be treated, but it also makes it more apparent and thus present. That's a complicated phenomenon, but I do think it's present. And it's reinforced by TikTok in particular, and Instagram, where you see a lot of mental health, which is then, if you have it, fed to you. So let's say this boy with anxiety problems receives that feed that others have it too, and how they look, he will recognize it, he will talk about it, and he will say, oh my God, I have it, which is positive that you think you can do something, but it can also be negative in the sense, oh my God, I'm sick. I have a disorder. So that's a long answer to your wonderful question.
Yeah, thank you. You know how some mental health terms, like they're just being like thrown around? Like, do you think it's kind of related in that way?
Yes, I think that's related and it's very true. It's a very true phenomenon. I can give you many, many, many examples. So our society and our language is much more penetrated by psychiatric terms than we ever realize. As you said, bipolar, but also one of my friends constantly uses the term delusions. And if you really know as a psychiatrist or a psychiatric researcher what a delusion is, it's self-reference. For example, that you think everything is related to me. It's a very big concept, or even a concept that for certain reasons is used much more like narcissistic. Everybody now says, oh, this is narcissistic or you're narcissistic. I mean, it's a very rare, very extreme behavior, which we're using the term very globally. We're encouraging people to use it in a way. We're using it loosely, you could say, yes. And then the other thing that happens, we're constantly also replacing, of course, the terminology in mental health because it's stigmatizing. So we try to destigmatize by renaming, which is also a fascinating, term. It's going both ways, I think.
Okay, thank you. So my next question is, what does healthy development look like mentally and emotionally for kids and teens?
Yeah, I saw the question coming. It's a great question. To some extent, I'd like to make clear that everybody has to answer that for himself.
Mm.
I think it's a big danger for me as a researcher to, define it for everybody what healthy is. And I learned that from my training when I worked with somebody in a wheelchair, and he said, for me, healthy means something very different. And he was very vocal in what it meant. So we should make clear that it's your situation and your choices that determine that. Um, that's one thing to keep in mind, that you have it's your privilege, if you wish, to define what it means, for you as healthy. To some extent, if you're dysfunctional, I think it ends there. If you harm others, or if can't, can't make a living one day, that's a problem, I gather. The other thing is, if you ask it in the context of our discussion, you'll not want that type of answer. You'd want to think, how much mental health problems can I accept and still think I'm healthy, normal, and functioning, or is okay? That is actually here the real question. And I think the functioning is important. So the minute the DSM, this manual of the psychiatric disorder of American psychiatrists, is very good in it, that it says, psychiatric problems really matter when they start impairing your function. I don't think I have many better definitions than that. So if it really means that your school performance, your relation with your parents, your boyfriend, in your sport club, or your music that you're playing is impaired, you don't want to practice anymore, or you're not making any progress anymore, or your school grades are bad, or you're fighting with your parents, then I think that is a sign of real problems. And at the same time, somebody who feels down, distressed, or sleeps poorly for a few days or several days or even 2 weeks, that is not in itself need be a problem, and can be tolerated quite well. And I appeal to people to think, part of life is that you have days, moments, times when you're not at your best, and there's no harm. And I like this generation at saying, they are very vocal at that. They've sort of much better than covering that up. They're ready to say, well, I don't feel that good today, but it's okay. It's quite a nice way. So I think we should be aware that some problems are acceptable, or at least part of life. And yet, when they start impairing your functioning, then I think you should seek help.
I remember the last time we talked, you said like I think that everyone at least experiences like some mental health problems throughout their lifetime.
Yeah, that's true. It's wow. I'm surprised. The people will think we chatted for hours and many a times. It's not true. We met once and briefly
Yeah.
chatted in the group, but it's true. We said that, and I said that, and it's one of the revelations of studies that have been conducted since the 70s, 80s, and following up people across their life course and measuring psychiatric problems every year, every 2 years, or very regularly. And they came to the conclusion that um, depression alone, where we first thought that perhaps 20% of people get depressed in their lifetime, that is an underestimate. I think the Swedish showed it could be up to 40%. And then New Zealand, the studies, they're the best studies we have in the field that followed people for 50 years, 40 years till they were, 50, and repeatedly assessed. They showed that 75 to 80% will have one psychiatric problem lasting 2 weeks or more in their lifetime. If you calculate alcohol disorders, depression, aggression, everything together, bipolar is not common, but all of them together, obsessive compulsive eating disorders, if you lump it all together, with the big disorders being depression, anxiety, and substance abuse problems, then you do get that it's clearly more common to have had a disorder once in your lifetime than to not have had a disorder. And of course, that's an age effect. So somebody like me who's in their 50s, it's much more likely that I have had a disorder than you. But most disorders will have occurred, or many disorders will have occurred in the first 25 years of life, and many after are recurrent disorders.
Interesting. How do recurrent or disorders come back?
How do they come back? Good question again. How do they come back? First of all, the best predictor of having a disorder is having had one. So if at any age, in any situation, if I've had a depression you have not had, then the likelihood that I will have another disorder is much higher. It's simply having had one is recorded. So it's most disorders will come back or will have a chance to come back. That doesn't mean if you have one depression that the disorder is 90% to come back. It's actually not at all. It is not so much more than 50%, I think. Um, and that's over 10, 20 years. So it's not that they all come back tomorrow, not at all, but they are likely to return. What I would say, it's not so easy to prevent a first ever disorder, although you can do that. But good treatment, good social networks, for example, exercise or even reading, they all help you prevent the recurrence of a new disorder. So they come back because you're vulnerable for it. They come back because you're not treated successfully for it. And they come back because you're not preventing the occurrence by lifestyle and things. So it's, I actually think mental health problems are quite treatable. Certainly preventing the recurrence, we can do quite well. And, sleep is one of the things you can take care of.
How much of mental health is biological and how much comes from someone's environment or upbringing?
This is a tricky question to answer. I'll tell you two things why it's tricky. It's a bit technical, but I do want to make the point, two technical points here. One technical point is biology is not the same as genetics. So we can talk about nature versus nurture. Now, nature is typically genetic disposition, meaning what you inherit in your genes. If you talk about biology, you must know that the environment can change my biology. So I could have a depression because I lack vitamins in blood. That could make me depressed, which is not a genetic problem, but it is clearly a problem of biology. So if you take biology versus environment, it's not a sharp distinction because the biology can be environmental. The environment determines your health, your vitamins, your nutrition. And your alcohol is a biological agent that can be toxic in your brain. So is that biology or is that environment? So normally we discuss that as nature versus nurture, meaning genetics versus that. That's one technical remark. Yeah, so that's second remark is if you say one's or someone's, that was your question, someone's disease. We normally don't like to say nurture versus nurture on someone's because that's very hard to define and nearly impossible. We do that on a group level. So we do that on the statistical level across groups. We say for 100 people, how much of that would be depression, biology, how much would that be environment? That's much easier to conceive because the individual, it's always both. It's always the interaction, and I can't say, oh, your depression is genetic. That doesn't work. We can actually only say that in a statistical sense over groups. And why is that relevant? Because the funny thing is, which we realized, that this genetic effect over groups, the contribution to the disease, differs by societies. I'll give you an example. And that comes from twin studies from a woman who was not really taken serious for many years, but Sandra Scar worked hard on it to show that in the twin research where we take this, what is nature versus nurture, the results are very different in the classical studies that she saw published than in studies of poverty conducted in inner city Los Angeles and comparable. If the environment is rougher and more tough, then the genetic goes down and the environmental contribution goes up. So if I have more environmental variation and pressure, I see more of the disease risk attributable to the environment. So you can show that. I can give you another example, which is more cognition, but it's well documented. The heritability of academic achievement is the highest in Norway because the children go to good schools uniformly and they can get to be tested to their optimal potential. In the US, the academic achievement heritability varies even within Los Angeles because it's lower in the inner city where the schools are poor and higher where the schools are good. So society determines the ratio of nature versus nurture, which is very complex but very important because it shows how relative this is. You can also see that in animal experiments, if the animals are genetically exactly the same, then everything is the environment because they're all the same genetically. So we must be aware that we actually should strive to create a society like Norway where the genetics is important because that means we have given everybody the environmental opportunities they deserve, which is complicated but very charming to think about. Now, if you then ask the question again, okay, I know all this, I accept that it's about genetics, not about biology. If I accept it's about groups, what can you say? Then I can tell you that we believe that ADHD and autism, which disorders I study a lot, are probably no less heritable than 70%, up to 85%. On a group level, most of what you see as autism is inherited genetically. Now, that doesn't even mean it's inherited by the parents because it can occur as damage during conception. For example, the sperm can have DNA damage, and that can give you autistic traits which are genetic but not from your parents. So that's all said. We think that these disorders are highly heritable. When we come to anxiety and depression, it goes down to 40, 50%. That means that psychiatric, child psychiatric, but also adult psychiatric disorders are more heritable than heart attack and body mass. So when we talk about parenting, when we talk about schools, when we talk about peer, when we talk about social media, we have to know that we're in a field where many of the effects are heritable. And that's just quite outspoken there. There's very good evidence for that. So we shape our environments, we make people sick, but who gets sick is partly strongly determined by our genes.
Like generational trauma, do you think it's like it's probably passed through like both ways, right? Based on how like the parent treats the kid, and is it also in their genetics too?
Yes, but I would like to nuance or explain that to our listeners well, because
Oh,
it sounds very easy. So let's see. Parents that have inherited or have been traumatized certainly are more likely to create an environment from perhaps abuse or less optimal parenting or being stressed themselves that is non-optimal for the child. That is true. That is just environmental. So they create that environment, being perhaps they are just more stressed, or they are poorer, they have less access to means, they're not educated, or they're just more emotionally dysregulated and shout at the children, or just beat them, do physical discipline. So that does happen. It's undoubtedly, it is it's a sad factor of life that this runs across generations. The other thing is that the parental propensity, so the risk that parents were traumatized, is always also possibly related to your risk. So let me put it this way. If you have in a family a high risk for substance abuse disorder or ADHD, it is indeed genetic and is related to the poor parenting, but it could be that the risk comes from the mother or the father to the child because there is just genetic transmission of risk for ADHD. 50% of your genes you pass on as the father to the child, and if you have lots of genes, genetic variations that increase the risk of ADHD in the father, then that makes it harder for you. And that will often be related to environmental things, but it's not causally, it's just a genetic transmission. So you're right. Yes, it is transmitted in the genes, but it's the risk and yeah, yeah. I hope that is clear.
okay. Yeah, that was clear. Thank you. Since we're running out of time, I'll give you two more questions, okay?
Right. I'll be short, more for
Okay.
once.
How can students support their own mental health if they don't have any access to therapy or counseling? And what is something about children's mental health or teens' mental health that you wish more people understood?
Hmm. Last one is tricky. It's a wonderful final question. But the first one, what can they do if they have no access to mental health? No access to mental health in the US can be common because there's no providers, there's long waiting lists. I would like to point out there's many less formal. It doesn't have to be a child psychiatrist. I mean, many people have access to a GP, or they can help there, or there's online resources. Some of them are actually very good now. Let's be honest, there's very good apps for sleep problems nowadays, and programs. So there could be that. But there's also informal ways. I mean, if you look after yourself in the terms of being active, physically active, if you make sure that you care for your relationships, then that'll normally return itself and they'll care for you. So that's what you can do. You can also structure your life. Often, if you read, you do your homework. Often adolescents feel overwhelmed. And that is one of the reasons, the distress that they sort of glide into into mental health problems. And I think, what can you do if you're distressed? Well, one thing is to really offload activities or duties, just, do that actively. And the other thing is just force yourself to do things so many hours and then end it there. It's like the homework. Okay, if it's endless or whatever it is, then just try to do it in portions, work there, but also take your time to read. And, if you say, for example, even television or screen time, just, I wouldn't cut it out totally, but I would sort of limit it. Tell you, you do an hour, you can set the clock and then do it, and then don't hang in front of it hours just because you're feeling down. That's the one thing. So, what I wish they knew. Actually, I think adolescents know a lot about mental health problems. That's what we started off in this conversation. This is the most knowledgeable group in mental health that we've ever seen in a good way. I mean that as a compliment to this generation of adolescents. And I actually think they have a very good understanding of the impact. Uh, and I've seen very good examples in my daughter's school, how schools can deal with mental health problems. And I would think my advice, and that's a bit of a personal advice, I think let's talk about what you can do for other people's mental health problems, not only your own. We've talked a lot about what you do if you have your own. I think the other thing that adolescents must realize is that all around them there are mental health problems too. And I think I'd really like to appeal, whatever these problems are, there should be an understanding in the sense that you tolerate, accept it, and leave people as they are if they have weird habits. So I think what they can do is be very sure that they don't bully. That's one thing, but even if they see bullying, that they defend. I've seen in school programs that one of the most protective aspects that adolescents can do if they support, but not just saying, "Oh, you've got a problem, it's so bad," and "Oh, let's talk about it," but just include people with problems in your regular activities, and just you don't even need to discuss it much. But if you have a party, if you go for a trip, or if you have a ball game, whatever you do together, social activities where you just include everybody is one of the best ways to deal with mental health as a group. And not to bully, but also stand up for the people who are a bit awkward. That's what I would suggest.
Okay, thank you so much for joining us. We are the YB Teen Health. My name is Samantha, and I'll catch you guys next time.